Good evening, everybody. This is Dr. Sean Orr. I'm the Vice President and U.S. Medical Director of Orr Medical. I'd like to welcome you to this month's broadcast, or webcast, where we're discussing monitoring of cerebral blood flow after stroke. This is a part of a series of discussions that we're having that refer to the modern monitoring of cerebral blood flow. And in this particular episode, we're going to talk about stroke specifically, focusing on the effects of stroke and cerebral blood flow. First, we'll go through updated stroke definitions to make sure that we've got everybody on the same page, and we'll talk about stroke types, subtypes, and classification. We'll talk about the fundamental commonalities that exist between different stroke subtypes, which really comes down to limitation of brain blood flow. We'll discuss the advances in restoring flow that have taken place over the last decade, and we'll introduce the C-Flow Cerebral Blood Flow Monitor to you today. We'll talk about applications of the C-Flow in the stroke population. So I'd like to welcome everybody here tonight. We have attendees logging in, and I would suggest that as we go through this webinar, feel free to post your questions in the question section for your GoToWebinar control panel, which should be in front of you right now. This is a session that's going to be recorded for future reference and future use. It will be present on the orneem.com website, and it will also be made available through our YouTube channel for future reference as well. So feel free to invite your friends, and let's go ahead and get into it. So modern stroke definition today really draws the distinction between the objective pathophysiology that we see on imaging studies and the clinical presentation, which includes the signs and symptoms. So stroke traditionally is a clinical syndrome, and it was, of course, recognized many years before modern imaging became available. And as time has gone on, we've seen modifications in the way that we're defining stroke. And stroke has traditionally been defined as a time-dependent phenomenon. So the more time that has passed after the onset of symptoms, the more damage we think is going on. These days, now because imaging studies have become so sophisticated, we're understanding much more about the difference between the clinical phenomenology of stroke and the objective pathophysiology that we see. And recently, in 2013, Dr. Sacco led a consensus group that updated the definition of stroke for this century. And refer you to this paper here, the Statement for Healthcare Professionals from the American Heart American Stroke Association, published in the Journal of Stroke. It's a very good document that gets into the definitions. So this slide here basically goes through the upshot of the consensus document. And in the consensus document, authors got very particular and specific in defining the difference between the clinical phenomenon and the objective evidence. So let's just go down this list briefly, and then we'll break it out into the different subtypes before we get into how cerebral blood flow folds into all of this. So the major categories of stroke condition break down as follows. There's central nervous system infarctions, which are parallel to ischemic stroke, and silent CNS infarctions. There are intracerebral hemorrhages, stroke caused by intracerebral hemorrhage, silent cerebral hemorrhage, and then we'll focus on subarachnoid hemorrhage, the stroke caused by subarachnoid hemorrhage. And then there are a couple of other categories to look at: stroke caused by cerebral venous thrombosis and stroke not otherwise specified. So let's talk about CNS infarction. CNS infarction is impacts the brain or the spinal cord or the retina. Okay, so CNS infarction is brain, spinal cord, or retinal cell death attributable to ischemia. Okay, and that's based on evidence, basically evidence that we see in pathology or imaging or other objective evidence. It also is based on clinical evidence of cerebral spinal cord or retinal imaging ischemic injury based on symptoms persisting greater than 24 hours or until death, with other etiologies excluded. So CNS infarction also includes hemorrhagic infarctions, and this is a subtle nuance of language here, but a hemorrhagic infarction in a nutshell, is an ischemic infarction that's undergone hemorrhagic transformation. And many will make the argument that all ischemic infarctions, to some degree or another, have an element of hemorrhagic conversion, but some more than others. And I'm sure all of you have seen that apparent bland infarct that has undergone hemorrhagic conversion that is obvious on the macro level with imaging. So an ischemic stroke is to be differentiated from the CNS infarction. The stroke itself is an episode of neurological dysfunction caused by the focal cerebral, spinal, or retinal infarction. And this is an important distinction to make. If we go back to where the term stroke originally originates, stroke was thought to be, back to medieval times, the striking of the hand of God on the unbeliever. So there really is a sudden onset punitive type of mythology associated with stroke, and it really is the clinical phenomenon itself of the symptoms that are caused by the ischemia and the infarction that take place underlying the syndrome. A silent CNS infarction can happen. It is possible to actually have an infarction of the brain, the spinal cord, or the retina without actually having clinical symptoms for a variety of reasons. The tissue that's involved may not be eloquent tissue, or it may be in an area that is prone to developing neglect when it's involved. So a silent CNS infarction is defined, involves the imaging or the neuropathological evidence of a CNS infarction, but without the history of acute neurological dysfunction attributable to the findings. So really, as our technology has gotten more sophisticated, and I would say specifically diffusion-weighted imaging on MRI really has changed the way that we're looking at the whole issue of stroke and infarction. It frankly is not common, but also probably not uncommon for some of us to have seen times when a patient presents for a variety of reasons and an MRI of the brain is ordered and there's clear evidence of an infarction, but the patient doesn't endorse symptoms that relate to that infarction. So this is an important subcategory to consider. Intracerebral hemorrhage is a focal collection of blood within the brain parenchyma or the ventricular system that is not caused by trauma. So again, this includes parenchymal hemorrhage after CNS infarction. And intracerebral hemorrhage typically is the result of the rupture of one of the small perforating blood vessels deep inside the brain. Many of us have referred to this as the 4 Ps, but there are basically 4 different regions of the brain that seem to be particularly prone to intracerebral hemorrhage because of the acute takeoff of small vessels, such as in the lenticular striate territory. And that's to be differentiated from stroke caused by intracerebral hemorrhage. So the stroke itself is a rapidly developing clinical sign of neurological dysfunction that is attributable to the actual hemorrhage itself within the parenchyma or ventricular system, with the caveat that it's not caused by trauma. And again, as with ischemic infarctions, it is possible to have silent cerebral hemorrhage. In this case, a focal collection of chronic blood products, again within the brain parenchyma, subarachnoid space, or the ventricular system. And typically this is seen on neuroimaging or neuropathological examination, but in the setting where there's no trauma and there's no actual clinical history of acute neurological dysfunction that could be attributable to that lesion. So if you go back a decade, probably it was not common for us to see this kind of phenomenon. But as modern imaging, especially blood oxygen level dependent imaging, bold imaging, and MRI has become more common, we're seeing more patients who present with silent cerebral hemorrhages, maybe even what we call microhemorrhages. So it is entirely possible to have small bruises in the brain, if you will, or small hemorrhages that essentially are not seen. And again, this is to be distinguished from the stroke caused by intracerebral hemorrhage, which is the clinical syndrome itself in the setting of intracerebral hemorrhage. Let's distinguish this from subarachnoid hemorrhage. This is the syndrome in which there is bleeding into the subarachnoid space. Now, the subarachnoid space is the space between the arachnoid membrane and the pia mater of the brain or spinal cord. And if you go back to the basics, the pia mater is the part of the meninges that is most intimately invested against the brain and spinal cord structures. And there's a gap between the pia mater and the arachnoid membrane. And largely, this gap is traversed by arterioles and the arteries of the brain. So the most common cause of subarachnoid hemorrhage we know today is actually trauma. The second most common cause is a ruptured cerebral aneurysm. And each of those etiologies has its own individual and unique pattern of spreading hemorrhage throughout the brain. Now, the stroke caused by subarachnoid hemorrhage is, again, the rapidly developing signs of neurological dysfunction and headache because of bleeding into the subarachnoid space. And so this is to be differentiated from traumatic subarachnoid hemorrhage, again, stroke being the rather precipitous, sudden onset of dysfunction that is not attributable to something else. So in this case, we don't refer to the subarachnoid hemorrhage that is caused by trauma as stroke caused by subarachnoid hemorrhage. So it's a fine, nuanced, distinction, but it's one that is worthy of note. Let's turn our attention to the venous side. So stroke caused by cerebral venous thrombosis is the infarction or hemorrhage into the brain, spinal cord, or retina because of thrombosis of a cerebral venous structure. And symptoms and signs are caused by reversible edema with or without infarction and do not necessarily qualify as stroke. So a stroke caused by cerebral venous thrombosis is essentially, again, the clinical phenomenon that occurs when there is a backup of blood flow because the venous outflow tract is obstructed. And those of us who have taken care of these patients know that oftentimes the edema that occurs in the affected territory can be quite significant, and the clinical syndrome associated with it can be quite disasterly. And let's go ahead and look now at stroke not otherwise specified. So again, this is a clinical syndrome. It's an episode of neurological dysfunction, and it's presumed to be caused by ischemia or hemorrhage lasting greater than 24 hours or until death, but again, without sufficient evidence to be classified as any of the above other stroke syndromes. So it's a bit of a garbage pail category in other category, but for the most part, I think most modern stroke doctors will, for all intents and purposes, find that most strokes will fit into one of the other predefined categories. So let's turn to ischemic stroke subtypes. I think it's useful to review this because ischemic infarctions come in a variety of different flavors, if you will, and largely due to their etiology. This particular classification comes from the TOAST study, trial of ORG 10172, an acute stroke treatment, published in JAMA in 1998. This study was particularly focused on whether or not a novel low molecular weight anticoagulant would have clinical utility in reducing risk of stroke. And as part of this trial, it really was what makes this trial such a hallmark trial in many of our views, that it, for the first time, really did a good job defining ischemic stroke subtypes. And they are right in front of your screen to read here. Atherothromboembolic, cardioembolic, lacunar, other, and unknown are the main categories. And the terminology is important to pay attention to here. Atherothromboembolic strokes largely come from vessels that are suffering from the effects of atherosclerosis. Usually these are the extracranial carotid arteries, usually at the bifurcation, and thrombotic material that generates at a platelet-rich site of thrombosis at the plaque eventually embolizes and travels downstream, at which point it lodges into a smaller vessel, creating an ischemic infarction. Cardioembolic ischemic strokes are, just as the term indicates, they come from the heart. Typically, these are smaller pieces of platelet-rich material that have accumulated on heart valves or in heart chambers, and probably atrial fibrillation is the most common etiology of cardioembolic strokes. Lacunar strokes occur at the level of the microvasculature and the small perforating vessels deep inside the parenchyma of the brain, typically due to the phenomenon of lipohyalinosis that is caused by chronic hypertension and or diabetes. Other is a useful category in that it really points to the idea that there are some rarer types of stroke syndromes or etiologies, such as hypercoagulable states, autoimmune-related issues, and the like that can lead to more rare types of stroke. Other also is another way of saying that more than one of the above etiologies may be responsible, and it's hard to distinguish. So if a patient with atrial fibrillation presents with a small lacunar appearing infarction and has densely calcified carotid arteries, it sometimes can be hard to commit to one of those causes, and typically they would be graded as other. Unknown is a category that is there because sometimes we just don't know what the etiology is, and it doesn't seem to fit in the other well-defined categories. It is rare, I believe, in my clinic, certainly in most practicing neurologists who deal with stroke. It's rare to actually end up settling for the category of unknown, but it's there just for the study purpose, to be clear. So the fundamental commonality between all of these different stroke subtypes is that there is limitation of cerebral blood flow. Interruption of the flow essentially leads to a cascade of events. Obviously, there's a lack of oxygen delivery to tissues. Maybe more importantly, there's a lack of glucose delivery as well. And from a certain point of view, if you think about it, oxygen extraction can be altered over time, and the neuronal cells have the ability to increase their oxygen extraction. But there's no real good glucose store in the brain. And since all energy, whether it's aerobic or anaerobically produced, comes from glucose, maybe it could be argued that glucose delivery through blood flow is almost even more important to pay attention to than oxygen delivery from a certain point of view. Interruption of flow also deprives the tissue of waste removal, which is an issue because the buildup of toxins has a secondary effect on causing further damage to the brain. So the consequences are tissue ischemia, tissue infarction, and the buildup of free radicals and other waste products that have a deleterious effect on tissue that is at risk. And it is for this reason that we've seen major advances over the last 15 to 20 years in the attempts to restore flow. In 1995, the National Institute of Neurological Disorders and Stroke published their seminal papers on IVTPA and their effect on reducing the long-term morbidity and mortality from stroke. Soon thereafter, we saw a growth in the use of intraarterial recombinant tissue plasminogen activator. And it really wasn't long thereafter that we started to see angioplasty and stenting, the delivery of suction catheters deep into the brain, such as the penumbra device, corkscrew wires, a variety of different tools, such as the Mercy device. And now we're seeing this evolution into the newer devices, such as the stent retrievers, which are a combination of a stent-like structure that actually pulls clot back into a suction catheter, almost a multimodality approach to clearing out thrombi that are occluding brain blood vessels. I would say, though, that as much as great as it has been over the last 20 years to see these advances take place, we're still left with this conundrum, and that is that in none of the trials that have been performed here, in none of the experiments that have come out over the last 20 years, has anybody successfully, reliably measured cerebral blood flow. So while we have amazing technologies that have come to the market, amazing medications that have flown through preclinical data and somewhat hit the wall when they get to later stage clinical trials, it just begs the question whether maybe part of the problem is that we're not measuring cerebral blood flow. It is quite striking that we continue to see negative trial after negative trial when things like the clinical exam, for example, are being used as a surrogate, or at best neuroimaging is being used as a surrogate. And we've seen the industry go through contortions to come up with reliable measures and indices of cerebral ischemia versus infarction, what constitutes the ischemic core versus the penumbra that's at risk. And yet all of these advances have taken place without any insight into cerebral blood flow. And this is why it's so exciting, frankly, to be here to be able to introduce the C-Flow monitor to you and to the industry. This device is a revolutionary device that measures microvascular flow. So we're essentially looking at brain blood flow at the level of the microvasculature, probably around the level of the gray-white junction. The C-Flow by Orne Medical is a bedside monitor, and it actually measures flow continuously and non-invasively, and it does it real time at the bedside. So the advantages here are vast. It really, in many respects, is the holy grail of neurointensive care. We've been waiting for decades for something like this to come on the scene. There are many other devices that measure cerebral blood flow. Some of them actually give real-time flow, but they all have their disadvantages. If it's not an imaging device that you need to send the patient away for to get a static image, then it likely requires a burr hole or craniotomy in order to be implanted deep into the brain, or it's a surrogate marker such as transcranial Doppler, which, as useful as it is, still only gives flow velocities. So when we start to contemplate a device like this, the C-Flow in stroke, a variety of potential solutions come to mind. And I think that all of you who are hearing this talk today will probably start to think about this the way that many of us had. And when we start to think about measuring cerebral blood flow continuously at the bedside, we start to wonder, are we really adequately reperfusing the brain? So think about solutions, measuring the adequacy of IV thrombolysis, or how well we're doing with mechanical embolectomy. Are we really restoring flow on the small vessel level? How well are shunts performing during carotid endarterectomy? Are we actually capturing the early changes of cerebral vasospasm after subarachnoid hemorrhage? And could monitoring that actually make a difference in terms of preventing secondary ischemic cerebral infarctions? Imagine the perihemotomal penumbra that develops after an intracerebral hemorrhage, the compressive effect on the surrounding tissue leading to ischemia and infarction. Well, wouldn't it be nice to be able to measure that? Or how about emboli? Detecting emboli on the segmental level at regional territories throughout the brain. It really even opens up other possibilities in terms of measuring the effect of stroke rehabilitation on cerebral blood flow, and as well as the effects of other conditions. It's not common, but not uncommon for us to see complicated migraine in the setting of stroke. And if you think of the classic basilar migraine that can lead to basilar ischemia, well, wouldn't it be nice to be able to measure that and monitor it over time and gauge the effect of your therapy and your intervention, not simply rely on the clinical exam only? Think about the effects that take place in the lateral prefrontal cortex of patients with sleep apnea, particularly post-stroke. There's a growing body of literature that would suggest that sleep apnea following stroke actually worsens outcomes, and to some degree it would be very appealing to be able to evaluate the effects of sleep apnea on brain blood flow after stroke. So these are some of the potential solutions that start to emerge when you think about how a device like C-Flow actually can be applied in the setting of acute or chronic stroke. So I would just wrap up this part of the talk before opening up to questions, and I would conclude that obviously stroke impacts cerebral blood flow in a negative fashion. It appears that there are numerous conditions that maybe could benefit from practical monitoring of regional cerebral blood flow. And I would just like to reinforce that the C-Flow, which is just now coming onto the market, is a blood flow monitor that is really hitting all the high points. It's non-invasive, it's continuous, it is at the bedside and therefore portable, it records in real time. We like to think that it is feasible that this device may be poised to set the new gold standard. And of course, much of that depends on how well the market takes it up and what you think of it. So that's this week's webinar focused on stroke. I think I'd like to open up right now to questions from the audience and take your questions here for further review. And our first question is coming in, can cardioembolic stroke be monitored with C-Flow? So this is a very interesting question, and there are probably two parts to the answer. I would say the first part is, can we detect the effects of ischemia during the acute phase of cardioembolism. One of the appealing aspects of the C-Flow is that it is a regional cerebral blood flow monitor. It actually measures blood flowing within a cubic centimeter of space at the very white junction. And being a regional monitor, it is highly sensitive to changes in blood flow in the region. So from a certain point of view, if you're monitoring in a patient with known cardioembolism, it's feasible to think that if new embolism occurs in the territory you're monitoring, you may actually be able to capture that, which could be a warning sign for you to act on rapidly. From another point of view, cardioembolic stroke, when it does do its damage, does alter brain blood flow. And so I think that monitoring for the effects of your interventions in the territory of the cardioembolism potentially could be quite effective. And we're going to be studying that. So thank you for that question very much. And again, feel free to post your questions in the question and answer session here on your GoToWebinar control panel. And here's another question, very interesting. Can you use C-Flow to measure autoregulation? I would say that the answer is yes. We have some very exciting data that has come out on autoregulation, not only in the animal model, but as well in the adult patient model, adult human. Autoregulation, just to recap, for those in the audience who might not be aware of it, autoregulation is the phenomenon of maintaining a steady perfusion of the brain at the level of the capillary. The precapillary arterioles are responsible for controlling that process and dilate and constrict in accordance to how much pressure and how much change in pH and such are taking place in the body. The autoregulation is a fairly flat curve over most of the range of mean arterial pressure. What that means is the higher the pressure, mean arterial blood pressure, the more constriction will take place at the arteriolar level in order to restrict blood from entering the brain too much. Now there's an upper limit of that, and once that upper limit has been exceeded, then flow can't be contained, and this is where we see things like hypertensive encephalopathy developing. On the lower limit of autoregulation, when mean arterial pressure has dropped too far, eventually perfusion suffers at the capillary level and tissue is damaged. So when you get to the lower limit of autoregulation, eventually flow drops off as mean arterial pressure drops. But in between those two limits, for the most part, flow is maintained steady because of the principle of autoregulation. And with the C-Flow, we actually can monitor that over time. We measure cerebral blood flow at the microvascular level, and when you compare it moment to moment with a continuous mean arterial pressure tracing obtained from an arterial catheter, we can actually generate an autoregulation curve. You can actually watch when autoregulation fails in a patient who's had an area of ischemic damage, for example. So that was a great question. We'll take one or two more questions here before our webinar is up. So Dr. Maldonado is asking, does the presence of surgical wound staples affect the placement of the C-Flow sensor or the reliability of monitoring? So that's a great question. Since the monitor does actually adhere to or clips into an adherent pad that is on the scalp, clearly if there's a skin defect that is in the way of the adherent disposable pad that we call the smart pads, that does present a limitation to the device. So not everybody is going to be a suitable candidate for monitoring if there is a skin defect and such. In terms of staples themselves, since it's a metallic object and our device actually uses Doppler ultrasound as part of its technology, those echogenic staples theoretically could alter the signal that we get back. So we don't recommend that the device actually be used to monitor over staples or over brain pacemakers for that matter, or anywhere that there's a skin defect. Now, having said that, the good news is that the scalp is a fairly large area, and oftentimes when patients have a craniotomy that is frontal, the temporal region may be a suitable area to monitor from. So there may be more than one way to skin a cat. I'll take one last question. How does C-Flow play a role in monitoring vasospasm? So I assume that means delayed vasospasm after subarachnoid hemorrhage. But we're studying that right now, and I think we're expecting exciting results to come out of that. In a nutshell, you should expect to be able to detect, if nothing else, to detect an improvement in cerebral blood flow on the basis of your interventions. So if a patient is going to the cath lab or to special procedures to have angioplasty done, and you're monitoring, you'd like to be able to see an improvement in cerebral blood flow as your intervention is going through. Some of us imagine a day when we're actually monitoring patients with subarachnoid hemorrhage over the long term, and much of that needs to be worked out by you in the industry. So that's a great question. Well, our half hour is up. I want to thank everybody for joining us today. This has been a pleasure to speak with you about the application of C-Flow, our ultrasound tag light monitor in stroke states. Please stay tuned. In a month from now, we will have our next webinar, in which case we will focus more on the issue of subarachnoid hemorrhage-related vasospasm. And I would also just invite those of you who may be going to the upcoming Neurocritical Care Society meeting in September to join us on September 12th at our Neurocritical Care Symposium, in which we'll have 5 world-renowned speakers talking about their particular clinical experience with ultrasound tag light and our particular brand of non-invasive cerebral blood flow monitoring. So thank you very much. Maybe you all have a very good evening, and we'll look forward to seeing you at a later date.